All right. Good evening, everybody. So I'm Dr. Salvatore over at University of South Florida. If you're joining us this evening, you're at our SAGES webinar, which is kind of a really interesting topic. This evening, we're going to be talking about basically how do you get some advanced training or additional training in advanced endoscopy, specifically, once you've kind of finished your residency and gone on to other training. But even that being said, there's definitely a lot of opportunities to also obtain some advanced training in the areas of endoscopy, really at whatever stage that you may be at. That could obviously currently when you're a resident, when you're a fellow, and even when you're at the attending level as well, you're going to have the ability to really go ahead and kind of get some additional training. So speakers this evening, we have Dr. Leena Khaitan over at Case. We have Eleanor Fung from Buffalo, Ryan Juza from Wisconsin, Dr. Eric Pauli from over at Penn State. And we're kind of just, we're Dr. Fung, Dr. Juza, unfortunately, kind of the world of surgery that we work in and live in. They're probably running a little bit late, so hopefully they're going to be able to make the webinar. But I think for the most part, we'll be able to have some conversations about their topic. But we're gonna start kind of jumping right into it. I think first up, we're gonna have Dr. Leena Khaitan, who a professor of surgery over at University Hospital, and she's the division chief of general surgery, director of the bariatric program, and also director of the esophageal program as well. And I'm really honored to have her here this evening. She's one of my she's the chair of flexible endoscopy for ASMBS. I sit as her co-chair, so kind of learning from her as we move along and kind of continue to push the boundaries of endoscopy. So everyone, thank you again so much for joining. And we're probably going to hold all the questions till the end. And Dr. Khaitan, if you want to kick it off, thanks again for your time.
Thank you so much, Sal. It's really an honor to be here and to be able to chat with you and to be on a panel with Dr. Pauli. Really excited to share a little bit with you about advanced endoscopy. You're like, we're not gastroenterologists. Why are we talking about endoscopy? And as you know, it's a really important part of your surgical training. And, we know for people like Dr. Pauli and myself, we've made it really a key part of our practices going out into the real world. And certainly when I trained in the late 90s, advanced endoscopy was really just a small part. There were only a few people, a few surgeons who made that a strong part of their practice. But really happy to share with you how to get some of this training now, now that we know that advanced endoscopy is such a key part of general surgery and part of what we do. And no matter what field you go into, whether it be bariatrics or foregut or hernia or whatever you're going to do in the general surgery space, that there's some place for advanced endoscopy. So let's see. It's not advancing. Hold on. Ah, there we go. All right. So I thought I'd start with a little bit of history for you all and kind of where endoscopy started. It started by Philip Bozzini, and his first scope was called the Licklider scope. You see one right here, the patient's kind of like tied down and they threw the scope down their mouth and tried to look down the different canals and cavities of the human body. And this was in the 1800s. And then in 1853, Antoine de Sormeau used his Licklider to actually look at the GU tract. He said, well, there's another orifice down there. Let me take a look at that. And then this evolved into the 1940s where we started looking at liver and gallbladder disease and kind of then took it the next step to the laparoscope. If we look at the evolution of flexible endoscopy, and that's really what we're talking about here today, the first true cysto, was done by Nietzsche in Germany. And he was able to use an actual light bulb by Edison to show the first, create kind of what our first modern optical system is. The first esophagoscopy was in 1881 in Vienna with Johann Michelitz of the Heineke-Michelitz procedure. And then the first gastro camera really came out from Olympus in 1952. And the coolest thing about this is that we could take pictures. And then in 1964, the lighting became even better once we started to add fiber optics and made it into a much more a single user device by the 1960s. And so this is kind of how we got to today. And now we use endoscopes in so many fields, right? We do upper endoscopy, colonoscopy, arthroscopy, thoracoscopy, bronchoscopy. Basically anywhere there's a lumen, an orifice, a space, we try to throw a scope in it because we're trying to do everything minimally invasively. And of course, patients appreciate that too, because it's easier for them usually to recover from an endoscopic or minimally invasive procedure than it is from a surgical procedure. Now, of course, we know that's where SAGES started. Forward thinkers like Jeff Ponsky, Jerry Marks, George Bursey, Tom Dent, all of these surgeons worked together to create SAGES in 1981. They said, you know what, we need a society, we need a place where surgeons who do endoscopy can come together, look at new innovations. And that's when SAGES started, way back when. Eric, were you even born then? I don't know. So exactly. So I mean, if you think about it, it's a pretty young society for being our largest general surgery organization, and really thrilled to be giving you this talk today on behalf of SAGES. So why do surgeons do endoscopy? Well, we're very forward-thinking people, right? When we see a problem, we want to fix it. Endoscopy was actually started by surgeons. And of course, we know endoscopy is an important aspect of what we do. SAGE's name says it all. It's the Society of American Gastrointestinal and Endoscopic Surgeons. That's who we are, right? We do GI surgery, we do endoscopic surgery. And so it represents our practice as well. If you look at the American Board of Surgery definition of what general surgeon should do, it says the general surgeon must also be capable of employing endoscopic techniques, particularly proctosigmoidoscopy, colonoscopy, EGD, laparoscopy, and operative choledocoscopy. And if you think about it, we kind of lost the art of the common bile duct exploration there for a while when ERCP was so prevalent. And now in a lot of health systems, ERCP is being harder to come by. And now we're going back to the common duct exploration, particularly with new technologies like Spyglass. So we have new technologies coming out all the time that are allowing us to do our jobs in a better way and a more effective way for patients. If you look at the American Board of Surgery case reporting, the most commonly performed procedure by a general surgeon is an upper endoscopy, and the second most common is a PEG. So we do a lot of these things, and of course, all of you now are required to do EGDs, colonoscopies. During your residency, when I was a resident, we had to do like 20 scopes, and I got those mostly doing bronchoscopies on a trauma service. But obviously the training has changed since then, and it's really important that you incorporate these endoscopic procedures into your training. I can tell you as division chief of general surgery, my surgeons all do, most of them do colonoscopy, upper endoscopy, because again, it's a large part of what surgeons do. And frankly, there's just not enough gastroenterologists to do all the colon screenings that have to happen in the world. And now we're doing so much therapeutic endoscopy in so many fields. So I thought it also would be helpful for everybody on the call, on the Zoom today, to really know what surgeons have contributed to this field. This is our field. We're the ones who contributed all these procedures. It was a surgeon who came up with colonoscopy. It was a surgeon, actually one of my mentors, Jeff Ponsky, one of Eric's mentors, who created the PEG tube. It was invented right here in Cleveland, Ohio. The PEG is similar, ERCP, colonoscopic polypectomy, band ligations, tattooing, stenting. All of these things were actually invented and started and discovered by surgeons. Just to give you a couple specifics as to who did what, the first colonoscopy was done by Dr. Terrell. Endoscopic treatment of hemorrhage was done by Drs. Gaisford and Sugawa. I think Dr. Sugawa is up in Michigan. First polypectomy by Dr. Shinya and Dr. Wolf. ERCP by Drs. McCune and Shorb. I just mentioned to you, lucky to know Dr. Ponsky. And actually, when I was a resident, I actually scrubbed with Dr. Gowder as well, who is a pediatric surgeon here at University Hospitals, and they're the ones who came up with the PEG. Variceal bandings from Greg Stigman and endobiliary stenting from Dr. Sahendra. So, surgeons are the ones who came up with a lot of these different things. And so therein lies the whole purpose of our discussion this evening, is that, the future of endoscopy. Now, we've talked a lot about notes in prior years. Notes has been around for a decade now. We actually had our own little notes society that has kind of was pretty big to start. This is natural orifice transluminal endoscopic surgery. And this was like taking out a gallbladder through your stomach or through the vagina, things like that. There's always new technologies, new techniques, and we're learning how to do old procedures better and less invasively. So let me give you a couple examples of that. This is a magnemosis. These are magnetic anastomoses. And these are technologies that have been in development for a long time, but now we're in human trials. If you look at the panel here on the bottom left of your screen, they're treating esophageal atresia with magnets. They put one magnet from below, one magnet from above. This is what it looks like on an x-ray. And what will happen is those magnets stick together so firmly that it burrows through the intestine. And over the 7 days it takes for it to kind of burrow through, an anastomosis forms and brings the two lumens together. Like, how cool is that? Now we're taking, like, leaks are a scary thing, right? When we do anastomoses, but now we're taking the human error out of it, so to speak, where, if your sutures are too tight, you're going to cause ischemia. If they're too loose, you're going to get bleeding and leaks, but the magnets make it so that the anastomosis happens over time. And perhaps maybe will even decrease the risk of leaks when it comes to anastomoses. This device here on the bottom right was actually can be delivered through a small delivery port, and even possibly through an endoscope at some point, and it just clicks together. And you can put it in through 2 lumens, or there's a laparoscopic delivery device. So again, you can make those anastomoses without making any big incisions, without having to do a bunch of sutures. These are really exciting technologies on the horizon that's going to make it better for us as surgeons and better for our patients. Also, endoscopic sleeve gastrectomies, all the craze. We're doing these more and more, and you can see it during our BESAFE lab, and I'll tell you more what that's about. Last week at ASMBS, actually, our surgeons were doing these advanced endoscopic techniques for the first time, and this is what their ESG looked like. You can see that the lumen that was left behind looks just like a true surgical sleeve. And this is a gastroplasty. We're just using suturing devices. We're collapsing down the walls of the stomach. So really, really cool things. So how do we get to train to do all these things, right? These magnetic procedures didn't come out when I was a resident. They weren't, ESG, endoscopic suturing devices weren't around when I went through my training. So how is it that this is something that I've incorporated into my practice and also get the opportunity to teach others to do? Well, it's through a lot of programs, through a lot of organizations like SAGES, where we get the basics, right? So fundamentals of endoscopic surgery was not a thing, but through the hard work of Dr. Marks, Dr. Pauli, and many others, FES is now a part of your training. So now everybody leaves their residency with good basic endoscopic skills. Okay, so how do we take it to the next level? And of course, you have fellowships as the next level, but there are going to be times where, you're done with your fellowship and you're like, well, how do I do this now? And this is another SAGE's endorsed program that we put together called BESAFE. So I do bariatric and foregut surgery. Those are kind of my subspecialties. I offer all the endoscopic procedures for weight loss as well as for GERD. And so SAGES and ASMBS actually work together to put together this program for exactly this purpose, to help surgeons who are in practice incorporate some of these advanced techniques into their practices. BESAFE was a very clever acronym we came up with called Bariatric Endoscopy Skill Acquisition Focused Evaluation. So this is not a credentialing, but what this is a kind of training certificate that anyone who's interested can take. Our requirement is that you have basic endoscopic training that you can evidence either by a log of endoscopic procedures, or by having passed FES. And then you can go onto our website, and you can see the website right here at the bottom of the screen. So you can go on the website, and then there's a series of videos. There's 8 videos that you can watch that'll teach you a lot of the different technologies that we can do in advanced endoscopy, things like clipping, using pigtail stents, placing stents over leaks, how to do remove foreign bodies safely, how to remove a gastric band that has eroded. You'll learn all these different videos, and that actually is free for you to watch the videos. So whether you want to get the certificate or not, any of you can go on to this website and watch these videos at any time. And then if you decide that you do want to go forward with the certificate, there's a written qualifying exam that has a small fee associated with it. And then once you pass the written, then there's actually a hands-on where you're going to get to be one-on-one with some of our leading advanced endoscopists in the country who will walk you through clinical scenarios and allow you to demonstrate your ability to utilize these advanced technologies in real patient case scenarios. And at the end of it, you have something that you can take back to your hospital and say, okay, I have my BESAFE certificate, and it hopefully allows you to work in better collaboration with your gastroenterologist, get access to your endoscopy lab, and all these sorts of things. So this was our BESAFE lab at our bariatric endoscopy lab at ASMBS. And so this was actually just a hands-on endoscopy course that we did separate from BESAFE. And so we had a didactic portion and then a hands-on portion where anybody who came to the course could learn all these different endoscopic instruments. They got their hands on. We had a stomach explant model, and people went from table to table to try these different techniques. And then we also did hold some of the BESAFE testing, and currently that's being held at usually the SAGES or the ASMBS meetings. So this is one mechanism by which you can incorporate more advanced endoscopic procedures into your practice. There are also a lot of regional courses. For example, here at university hospitals, this is just an old screenshot of a program we ran in 2020, endoscopic techniques in bariatric surgery. We did it again last year. We'll be holding this again in November of this year. And if you're interested in learning more about these advanced endoscopic techniques, you could come here. Other places do this, like the Cleveland Clinic holds some of these advanced endoscopic courses. Duke, you'll find a lot of institutions hold these advanced endoscopy courses. North Shore does it as well. And there are several more across the country. So you can just, most of these, for those of us who are SAGES members, will get SAGES endorsement for our courses. So you could go to the SAGES website and get a listing of some of those courses. I think you're going to hear more about SAGES things here from one of the other speakers. A lot of academic centers also hold these mini fellowships. For example, you can come here and visit Dr. Mark, say, Heller, achalasia is a disease interest of yours. You can come and you can spend a day with Dr. Marks where you'll get some hands-on training. You can observe some live poems. You're going to do some didactic and learn how to do this advanced endoscopic procedure. That's a more procedure-focused course. Gary Vitale will hold, does full year fellowships, but also mini fellowships for people interested in learning advanced endoscopy. We do these here. And then also Sages has partnered with some places in India where people can go to some of these centers in India and get kind of an immersive endoscopic experience. I think, we've had trainees go there, and within like 6 weeks, they did like 150 ERCPs. And this is in partnership with some industry. Other places where you can get some of these advanced endoscopy courses are places like EarCAD. You can actually find this online course on YouTube. And Dr. Swanstrom, Silvana Peretta, they lead these courses online where you can learn some of these advanced endoscopic techniques. And they bring in speakers from around the world like Galvao Neto and other people. These are fantastic courses. If you're interested in learning more, you can go on YouTube and watch this today. And then industry. Industry is great partners with everything that we do. First of all, when industry is looking at new innovations, of course, they're working with us, the surgeons, to provide them the clinical expertise, but they have the engineers, the resources, and some of the capital for us to also work with them to get these advanced technologies to the finish line. They also provide a lot of education and educational opportunities. So you can work with your local reps and say, you know what, I'm really interested in learning ESG. Can you tell me where the next ESG course is? So that's another way for you to get advanced training, particularly once you're out of residency and fellowship. And so the future of endoscopy is all of you. Take advantage of a lot of these offerings that are out there. And of course, you can always reach out to any of us at Sages, any of the Sages leadership. We're happy to guide you in the right direction if you are interested in looking more into some of these different opportunities. So thank you so much, Sal, for inviting me to be on this really neat panel and to share a little bit about the different training opportunities that there are out there.
Dr. Khaitan, thank you so much for that. That was actually it was a great trip kind of going through endoscopy and kind of seeing where we were from the very beginning to where we are now, where people basically kind of banging down the doors to get some additional training. The one thing that you mentioned toward the end as well, which I thought was really, really fitting, was sometimes there's a little bit of a disconnect there between a clinician and industry. I know there's some, barriers set up to, not barriers, but just there's some restrictions there for clinicians to collaborate with industry to get some of this additional training. What's your best advice for someone? Should they should they start approaching industry even as a resident, maybe just as a fellow, or we start asking them about, hey, how do we do these courses? Can you maybe even bring in some PIGX plants? And I'll give you an example, like Boston Scientific, Irby, a lot of them have always been really helpful with bringing PIGX plants, and so we can kind of set up some training sessions even in our own hospital. What's the best advice from that standpoint?
Yeah, the companies want you to use their products, right? So they
Right.
are a little self-interested, but at the same time, we couldn't do these things if industry didn't provide these products. So it is never too early to get to know your reps with the different companies. They are a phenomenal resource for information. One, they can give you the basics on how to use these different devices. They can share with you a lot of the devices that are out there. They can connect you with experts. They can tell you about courses that there are, and they can bring the training to you. And so if you have like a group of people who are all interested in learning something, they would be happy to bring, just like you said, some explant models and different things to show you how to use them so that you can implement them at your institution. So they're just as interested in training you as you are learning from them. So, the reps are a wealth of information in so many ways. And also, if you really want to know like what other surgeons are like at other places, your best resource is going to be the reps, because they are going to tell you what it's like to work with Dr. Pauli or Dr. Khaitan or Dr. Docimo, more so than any of their colleagues. Their colleagues are going to talk them up and say they're really nice people. And I know that they are nice people, but you get the real deal from the reps. So they're just a wealth of information, but they're there to help you, and never too early to get to know them. I know all my reps, and they're just great people. They're fun people, and they get excited when they see that you're excited, because it excites them about their products as well.
Yeah, that's awesome. That's great. I mean, even even BESAFE. I mean, all these programs. The recent endoscopy course that we did at ASMBS. It was pretty impressive. Even looking at some of the more advanced techniques like endoscopic suturing. I mean, we had a few surgeons that came through that course, and even after about 1 hour, they went from never holding the device to slowly becoming picking up the steps pretty quickly. So I think these courses they may seem like little flashes in the pan, pretty quick little sessions, but you really do leave the courses with some solid, solid techniques that you can hopefully bring back to the clinical setting. So, well, thank you so much. I know you said we have to hop off a little bit early, so feel free to stay as long as you like. But thank you so much for
Thank you. Thanks so much for having me. I'll hang for a little bit longer.
awesome. Great. Dr. Fung, I think there she is. Welcome.
Hello.
Dr. Eleanor Fung, she's assistant professor over at University of Buffalo. She's our co-chair of flexible endoscopy at SAGES as well. So she is thankfully she was able to make it. She literally just finished the case and hopped on. So thank you for your time. And she's going to be talking about getting hopefully some additional training through courses, specifically through SAGES. So thank you so much. Appreciate it. Thanks for being here.
No problem. I'm happy to do it. Thank you, Betty, for providing my PowerPoint for me. So I'm just going to be talking about SAGES courses after residency and what's available. But really, it's going to be a big plug for the SAGES Fellows course that we hold every year. Betty, you can go to the next slide. So the SAGES mission statement really does support this. As you heard from Dr. Khaitan's talk, the mission of SAGES is to really innovate, educate, and collaborate to improve patient care. So the real goal is really, at least for this talk, is really stressing on the education point. And we want to pass on our endoscopy knowledge to all of you, and how we're able to safely do that and incorporate it in your practice. So Betty, you can move to the next slide. So the fellows course is held annually, and it's open for all fellows, mostly MIS fellows, but first or second year fellows. Usually about up to 60 fellows attend each year. There's no cost to you to attend the course. So really, there's no reason not to attend the course. And registration is, again, limited to the first 60 registrants. But again, most of the time that all the fellows are able to attend, and there's not usually problems with registration. Again, you do have to be a SAGES candidate member. But again, I know most of you already are that already, having being on this seminar. So these are just pictures from the course we held in Buffalo a couple years ago, and we're going to be holding it again in 2025. But next year, you can go to the next slide, Betty. This year, it's going to be at the University of Wisconsin-Madison with Ryan Juza, who's also giving a talk today. It's going to be September 19th to 21st, so please be sure to register when those emails come out. You do want to attend. And I'm just going to show also the sort of like a sample agenda of what the course is like. It's pretty standard every year. We've made some changes recently to incorporate SPY Discover and lithotripsy, just an introduction into lap CBD exploration, as it is a part of cholecystoscopy. But you can see here, this is last year's agenda, but you can see here the course faculty mostly is the local faculty, but we try to also have faculty from all over the US and Canada as well. So you're able to meet SAGES experts that are known nationally. And you get to also meet your co-fellows. And I feel like that's a very valuable part Sal, you and I met at our Sages Fellows course when we were both fellows, and we're still here today. So I think it's a good testament to meeting your future colleagues, but also it's a good sort of networking event also to be able to talk to faculty, not necessarily in a sort of structured setting. Sometimes Sages can be very difficult to sort of network when there's so many people around, but at a course like this, you're definitely able to network not only with your fellow future colleagues and your co-fellows, but also with the faculty themselves. So you can see here, it's a 3-day course. We come in on Thursdays. It's mostly just to meet everybody, but Friday is when the course really starts. It's a full day Friday and a half a day on Saturday. It's a combination of lectures as well as hands-on portions. So we give, the faculty give lectures, and you can see here that there's a huge breadth of topics. It goes from how to deal with masses, polyps, ulcers, dealing with bleeding management, ulcer management. And then you can go to the next slide, Betty. This is just continuation of the agenda, but you can see there's lap CBD exploration, stricture and perforation management, dealing with dilations, different savories or balloon dilators, how to deal with double pigtail stents for leaks or Ovesco clips. And then you can also see there's advanced endoscopic techniques. It's one talk, but it's actually covering a lot of different procedures like EMR, ESD, POEM, POP, radiofrequency ablation for Barrett's. And then you can also have endoscopic GERD management. You can also get exposure to TIF, as well as overstitch. But then the second portion of that day on Friday is a hands-on portion. We separate you in 2 groups. We really strive to make sure that the hands-on portion, you guys are in small groups, max of like 3 or 4, that you're able to do it all hands-on. So we don't just talk about it. We want you to be able to be familiar with it. So we'll give you one large room station with foreign body management. So you'll be able to use the nets, the snares, the tripods, variceal banding, to be familiar with how to put on the bander, how to take out polyps, do saline lift polypectomies, using the Gold Pro and Hemospray, things you may not necessarily get to use on a daily basis or get to see, and you get to actually be able to learn how to set it up. The reps are there to help support, as well as all the faculty. So it's a good chance to be able to be familiar with all the different equipment in a very low stress setting. And we use a pig model, a pig stomach model that you saw in Dr. Khaitan's talk as well. So it's a very similar model as well. You have to do endovac. So there's a whole bunch of things that you're able to get exposure to. And you get to ask the experts how they do it, and then actually do it yourself. So it's a do one, see one type of approach. And then we have a special station that are breakout stations. So we have a big room, and then we have breakout stations to do more focused skill acquisition in terms of more specialized skills like Ovesco, Home, Pop, Spy Discover, EndoFlip, Bravo probes, TIF, and stent placements. So you can see it covers a whole broad breadth of topics. You may again, it's a good introductory course. You'll have 2 days to actually do hands-on labs, and you get to be with and mingle with your co-fellows and ask all the faculty all your questions in a very low stress setting. But again, I really want to stress how important, how great this course is, because it definitely was a good chance for me to meet my co-fellows and sort of meet the Sages faculty as well. So you can move on to the next slide. So I also want to stress, in terms of other Sages courses, the annual meeting is a good place where we always try to do different courses every year to sort of see what sort of go with what the new trends are. So in 2022, you can see we did endoscopic stenting and VAC for bariatric complications. And then you can go to the next slide. In 2023, it was how to do POEM and POP, and it was also all these lectures, all these sessions. You do have to pay for the course, I believe, but it's a combination of lectures as well as didactics. Lecture didactics and the hands-on. So you get to really do a combination of both, and you get to do it with the experts as well. And this year, you can go to the next slide. This year it was a hands-on course with endoscopic sleeves. I know Sal was part of that as well. But you got to be with the experts and learn how to do an endoscopic sleeve for, I think, a 4-hour session. So it's both lectures as well as a hands-on portion. The other part in the annual meetings is the Learning Center. You can go to the next slide. Sometimes Learning Centers changes every year, but there's sometimes a bariatric station, sometimes there's an endoscopy station. There's always a lap CBD exploration station. You can get familiar with Spy Discover there. It is with the industry as well, but the experts are there as well to guide you in how to sort of get familiar with the equipment. But there's always a cholecystoscopy station as well at the SAGES Learning Center. So it's not just restricted to the SAGES Fellows course, but every year we try to add different courses and also add things in the Learning Center for you to sort of advance your endoscopy skills. I think that's all I had to talk about, but I'm happy to take any questions or we can discuss this a little bit more, but I really just wanted to plug the SAGES Fellows course because it was, I can say from my personal experience, it was a fantastic course.
Yeah, I think we did it together, right?
Yeah, we did.
Yeah, right. I mean, gosh, going back a little bit of time now. Yeah, I mean, I think for the most part, it's definitely, even if you don't do any endoscopy in your fellowship, it's certainly just a really good introduction to some of the more advanced techniques. I think it's definitely kind of sets up a little bit of a basic foundation. What do you suggest though for, some of the fellows who, let's say they get out there and they feel kind of comfortable doing this stuff, but when they go back to the institution, there's really nobody there doing any of it. Is it best to kind of find a mentor, someone they can lean on before they go to the course, or try to at least, kind of strike up a good relationship with someone at the course? They have some mentorship when they go back to their institution. Because I find the biggest issue that most people have is like they go to these courses, they do these things, and they say, hey, I feel comfortable doing this, but then when they go back to the clinical setting, they have a little bit of trepidation.
Yeah, I do definitely understand that. I think that's where the networking does come important. Like you get the chance to meet with the faculty and introduce yourselves. If your fellowship is not necessarily heavily endoscopy based, you get to meet the faculty that are teaching it, and sometimes they're the ones that are going to be doing a little bit more in their practice. You can always try to reach out to them and see what other opportunities are available. So I definitely think that can definitely help.
Yeah. What about the rest of the panel? Since we got kind of the full crew here at the moment. Yeah, I mean, what's everyone's thoughts on that? I know we've, especially at SAGES, for instance, we're definitely trying to move toward that mentorship model, especially following these courses. I mean, what's the best advice to give those fellows who may not have, an advanced endoscopist at their institution that they can lean on?
I mean, I'll just share, I mean, that's the beauty of modern technology, honestly, is, I mean, exactly what we're doing right now. You can pick up your phone and you can FaceTime with anybody at any time. You're in the middle of a case. I do that now. I'm stuck on something. I'll call one of my colleagues and say, hey, this is what I'm seeing. What would you recommend? People are at your fingertips. So, you always have somebody to call, and then whoever you trained with is always happy to, once a mentor, always a mentor. They're there for you at any time. If you go to any of these courses, you can reach out to any of these people. And to be honest with you, if nobody's doing any of these things at your institution, I mean, that's awesome, because it gives you a wide open playground, and that you can really bring a skill set there that they've never seen before. And I would say, I'm pretty sure, Eric, when you went to Penn State, that there was nobody with your skill set there, and Eleanor, same at Buffalo. I think both of you actually were pioneers at each of your own institutions in bringing new technology. So they're probably even better poised to answer something like that than myself.
You have to be prepared for some people to not like that you have that skill set. It's almost always a gastroenterologist of some sort who does not have that skill set, but doesn't want you to do it either. And so there are some caveats to that. Even if you go back to your own institution, you do need the support of your boss to help make some of that dream a reality, for sure.
Yeah.
Awesome. All right. Well, Dr. Fung, thank you so much. If obviously if you can hang out
Yeah.
a little bit at the end, we'll have a little bit more commentary. But next up is Dr. Eric Pauli, who's a professor of surgery at Penn State Hershey Medical Center. He's the division chief as well of MIS Bariatrics. He's whom I trained with, so all the good things and all the bad things, all that blame can fall on him, because from an endoscopy standpoint. So appreciate that, and thanks for the time, and we're gonna chat a little bit about kind of other opportunities out there for some more advanced endoscopy training. So, Dr. Paul, I take it away. Thanks for your
Yeah,
time.
thanks, Sal, and it's been great to hear Dr. Khaitan and Dr. Fung kind of set the stage. Endoscopy is part of my life. I mean, I am a surgical endoscopist. To me, this is no different than saying that I do robot surgery or I do open surgery or I do laparoscopy. I do surgery with a flexible endoscope. And this is literally my day today. I wrote it down so that I wouldn't forget. I wrote it down. This morning, my surgical oncology team asked if I would scope somebody to see if they had an injury to the duodenum after a resection of a cholangiocarcinoma. I got a call about a patient who has carcinomatosis with ascites, no window for a PEG gastrostomy. We're going to put him on a CT scanner and do a combined endoscopy CT scan and find a window for a PEG so we can get decompressed. My bariatric team called me. They were taking out somebody's gallbladder who was having some foregut symptoms. They did an upper endoscopy at the same time, and it looked like her anastomosis was sutured shut, and there was a suture going right across the middle of a 2-month-old anastomosis. So we kind of took out some barbed suture and opened up an anastomosis. I got a consult for a patient with ALS who needs a PEG tube, and we're managing a patient who had an EJ anastomosis with an EVAC, and I got to do an EVAC change tomorrow. I'm not even on call today, and this is kind of the stuff that you can get if and when you make yourself available as a surgical endoscopist. I didn't intend to show any slides, but as Dr. Khaitan was talking and Dr. Fung were talking, I pulled up a PowerPoint here, which I think is reasonable to share. Let me share my screen here. You guys want that one there. The talk was about managing surgical complications and bleeding. Ignore that topic, because what I want to show you here in the slide deck are a little bit about how I think about managing problems, okay? And there's a few case examples here, which I think, may be illustrative of what an endoscopist and why having good endoscopic skills can help. This is a patient who belongs to my emergency general surgery service team. She had a trauma XLAP. They then closed her primarily and did a prophylactic onlay mesh because she was high risk for hernia formation. And unfortunately, her gastrostomy tube, which is over here, leaked. And as you can see, that leak tracked to the midline wound. And you can get the sense, maybe it doesn't project well on your screen, but there's some bile and some GI tract content coming out under the mesh here, okay? And so the question is, like, what do you do with this? You've got a piece of mesh that's grossly infected, an open wound, and a G-tube that's leaking in a patient who needs a G-tube. So we'll talk a little bit about it. I use endoscopy in all sorts of ways. I definitely use it to manage complications. And I think that, many of you get and should get diagnostic endoscopy in your practice, right? In your training, you should know how to do an upper scope. You should know how to do a colonoscopy. And there's some basic therapeutics there. We know Dr. Khaitan said that PEG gastrostomy is the second most common procedure that surgeons do. You guys should all be taking out polyps, regularly with your colonoscopies. Those are sort of the basics. The question is not the basics. The question that you guys want to know is, how do I get to the next level? How do I go up that ladder? And the problem is, a lot of people look at that ladder as something like this, where, Dr. Docimo shows some ridiculous case at Sages, and you say, well, that's great, but he's obviously some form of a wizard. He must have been well trained to do that. And I'm never going to get there. Okay. But what I like to remind people is that this is like additive waves. Okay. If you can learn how to inject something and you can learn how to dilate something, you are now prepared to manage a recalcitrant stricture, which requires you to dilate and inject. Okay. This is the basics of any surgical intervention that you guys will learn. You learn basic steps, and then you simply add those basic steps together, all right? A Whipple is just cutting some things in a certain space, sewing them back together. And endoscopy is ultimately no different than that. It's learning a few steps and then putting them together to make a much more complex procedure. You guys all know how to do a peg gastrostomy. I have no doubt. You may not know or have used endoscopic clips. If you have, then great. You are now set up to do a peg with a jejunal feeding extension. It's those two things put together, for most patients. Okay, so here's an example. This is a, let's see. I guess in 20, whenever I made these slides, I wanted to click on it. Here is a patient, turn this down. Here's a patient with a very nasty ulcer. They've had a GJ anastomosis, they've had an antrectomy, and you've got a very bad ulcer. And they've got an ulcerated anastomosis here, which is quite strictured. And we're going to place a balloon, and we're going to do a balloon-based dilation of that stricture. See here, where's our dilation? Under some fluoroscopy, we're doing a balloon dilation, okay? Again, this is stuff that these balloons exist in your practice, in your hospital already, and you can grab them and learn how to do it, okay? This is a suture foreign body removal. This is a patient who has a gastric bypass. This is a gastric pouch. There's some jejunum on the other side. They have an ulcerated anastomosis there, and there's a big piece of suture material eroding through that anastomosis. And so, part of why the ulcer is there is there's a big foreign body in the middle of it. And so understanding that removing that foreign body sometimes is as simple as grabbing and giving it a big tug. If you need to, sometimes you can get out a pair of scissors and cut it out, okay? But there you go, that's it, okay? Suture removed, ulcer eventually heals. So suture foreign body removal and dilation, here's a combination of those. This is a patient who needs, this is an injection therapy. This is a patient who is actively bleeding. This is a bleeding ulcer. So here's a GJ anastomotic ulcer that's bleeding, and you can see there's a little bit of a pseudoaneurysm there. We're gonna lavage it a little bit. Bleeding always looks worse when your scope is down in it. This is an injection needle. We're just going to inject the ulcer base circumferentially with some epinephrine, right? These are all things that you might see in your practice. If you're going to go into bariatrics, or you guys do bariatrics at your facility, two of these patients are bariatric anatomy. One of them had an antrectomy for ulcer disease. These are surgical patients. And from my end, these are surgical problems. Okay, so let's put all those together now, and let's see what we can come up with. So here is a patient. I haven't looked at this presentation probably in a decade, so forgive me if I don't know the slides line by line. But here's a patient with a stricture at an anastomosis. This looks like an esophago-gastric anastomosis. So this is a patient who had an esophagectomy with a gastric pull-through, and they've got a stricture and some dysphagia. And there, lo and behold, is a stricture, but also a suture foreign body at the anastomosis, okay? This patient, as I talked through this, had actually been dilated twice, utilizing sort of blind, bougie mechanical dilation, which A, I don't like because it's an anastomosis, and B, nobody is inspecting the anastomosis. And if they had scoped the first time, they would have seen the suture foreign body. This is a pair of scissors that I mentioned, just a regular old pair of endoscopic scissors. We're going to cut a little foreign body out there, and we're going to pull this guy out, okay? Next thing we're going to do is we're going to repeat the dilation. Actually, next thing we're going to do is we're going to get the rest of the suture out. But then we're just going to repeat the dilation, okay? And we'll do a balloon dilation like I showed you earlier. And if you're concerned that this stricture is going to be refractory, you can take your injection needle and you can inject some steroids in it, okay? So these more complex patients are ultimately just simple steps put together. And I want you to think about gaining the skill set to become a surgical endoscopist as understanding how to put those, different steps together, okay? Let's scoot forward here a little bit. My partner did a pelormyotomy on this patient, and our hospital cafeteria, for some reason, on day one, when she was supposed to be on some clear liquids, sent up a tray of actual food, which the patient happily ate, because, of course, she just had surgery and her achalasia is cured, and so her esophagus is now impacted. And so sort of on day one here, post-op from her surgery, we are cleaning out some chicken noodle soup. You can see carrots there, a couple noodles, some chicken bits with a Rothnet. Okay, this is pretty simple. We take some boluses out, you clear the esophagus. Again, if this is your patient, who it actually says 45 minutes later in the bottom corner there. If this is your patient who just had surgery, a day ago, ask yourself, would I want myself or my partner doing this, or would I want a medical GI doctor kind of doing this procedure on a surgical patient? Okay. This is a patient who has a colon polyp, and we're going to do a simple cold snare polypectomy, as we might do, except the polyp is near the hepatic flexure. And as we get the snare around it, oops, the scope fell back because we lost position. It loop reduced. And look at that. It's a perfect cold snare polypectomy, but it was kind of uncontrolled. And so we've got a little bit of bleeding from the wall. And again, it may have bled even if it was controlled. But just to make sure we don't have any problems, since it was a pretty uncontrolled closure, uncontrolled polypectomy, we're going to take an endoscopic clip and we're going to irrigate a little bit. And we're going to put a clip on the area where the polyp used to be, okay? And again, these clips are available in any one of your hospitals. They are universally available. And you can ask for these. They can come from the endoscopy suite or your GI suite, or maybe they have them in your OR. And you can learn how to put them on. So that's a clip being applied to an accidental cold snare polypectomy site, okay? I do pediatrics because pediatric patients need endoscopy too. And a lot of times the therapy that they need falls outside the realm of what a pediatric gastroenterologist wants to do, and also outside the realm of what an adult gastroenterologist wants to do. This patient was having lots of abdominal pain, and you can see they've got a juvenile hamartomatous polyp that's obstructing most of the GI tract lumen. This patient was told that they needed a colectomy and was sent to my pediatric surgical team, who said, Eric can take it out. And so you saw us putting a little plastic loop around there, that little blue loop. That's called a Pauli loop. And it's intended to snare the base of the polyp and kind of snugly tighten down like an endo loop, except, oops, we accidentally over tightened it. And you can see we just cold snared through the base of that polyp, okay? And so, again, if you accidentally cold snare through something, we're going to just place another clip here on the base of this. And this little kiddo came to the hospital thinking that she was going to get a colectomy, and left actually the same day with a polyp that was removed. And it's a benign polyp, and really no additional follow-up is necessary. I've now shown you multiple complications, and you're wondering if I'm a good endoscopist or a bad endoscopist. And I wonder that myself sometimes. We'll place a little clip there and we'll move on. This is a really easy place to learn how to do therapy, guys. If you are doing endoscopy on table, you can look for, you can do a leak test, right? And you can look for bleeding. This is a patient who had a positive leak test, and I was asked to run the endoscope while the team was looking for, on the surgical field, 2 surgeons were looking for and finding the leak. And while it was going on, I said, hey guys, your anastomosis is very oozy here. And you've got a few little pseudoaneurysms of the staple line here that, I mean, they're not pumping away, but how about while you're fixing that thing, how about if I put some little clips on these guys so that this doesn't bleed tomorrow or the day after and we're not back here? And so, again, when you're inspecting your anastomosis, these are very easy things for you to do, to put some clips on some areas that actively are bleeding or could be bleeding in the future. All right. This is a patient who was supposed to be getting an endoscopic revision of her gastric bypass. And when we put the endoscope down, we found this thing sitting in her esophagus, just floating away. We initially thought it was like a polyp or a mass, but we'd scoped her before and it looked like it was free floating. So we grabbed it with a little Rothnet there. This was my chief resident working with me. I remember this day very well. We took the scope out and we put it back in. It was a bloody mess. That was that same little Rothnet that I showed you that we used to collect food. As you can see, what we did was accidentally grab a tiny amount of mucosa, but when we pulled, we did a little strip mucosectomy there. Dr. Fung is making a face at me. Eleanor, how would you fix that? And my volume turned down there. We just closed it with some clips. We're going to speed this up a little bit. This is the same way I would close a poem. We made sure we didn't tear all the way through, and we just kind of closed it like a poem closure. I was hoping that Dr. Juza would be on because I realized that this video was here and Ryan was involved in this case. He was our fellow at the time. This is a patient who's getting a foregut operation here, and you can see they're passing a bougie down so they can do a wrap over the bougie. And they're having some trouble passing the bougie. In a minute, you're going to see why. It's not quite headed down across the EG junction. And that's because it goes through the esophagus. And so you've got a perforation. And when we scoped this patient, the tunnel that the bougie went through actually started very, very high, almost like a palm procedure. It started very high in the esophagus and tunneled down through the wall and then came out right there. So the surgeons closed that from the surgical side, and we went way up at like 25 centimeters in the esophagus and put some clips and closed it and made our lives a lot easier. I mentioned a PEG J. And again, this is something that you guys can learn how to do. These are gastrointestinal T anchors, which you can learn how to deploy to help hold a PEG in place. If you've got a PEG patient who's very high risk for pulling their PEG tube out, if you have a patient getting a PEG who's on high dose chemotherapy, who's a higher risk for leak, if you have a patient who has ascites or has a stomach full of content because they're obstructed, placing these little gastrointestinal T anchors is probably a good idea to help reduce the risk of a complication from that gastrostomy. And so you put 3 little T anchors in, and in the center, you place your PEG gastrostomy. And I'll skip ahead because you guys all know how to place a PEG. Okay. But then what we do is we advance through the PEG an additional feeding access, which is a 10 or 12 French tube that goes through the PEG. And it's got a little suture on the end that you grab, and you just drag it post-pyloric. You drag it all the way downstream, and then you use those endo clips, the same clips you've seen me use now 3 or 4 times, and you just pin that somewhere in D3 or D4 and hold it in place. Okay, and then you back the scope out. How about this one? This is a patient who presents with a paraesophageal hernia with an obstruction, and she's actively vomiting, and she's sort of sick for other reasons. This patient in particular was actively having a myocardial infarction at the time. And so taking her to the OR to reduce her incarcerated obstructed paraesophageal hernia and giving her a high dose general anesthesia and a somewhat long surgical intervention is probably a bad idea. And so with a little bit of extremely light sedation, we place an endoscope, and we're going to endoscopically reduce her paraesophageal hernia out of the chest by using a little bit of retroflex and a little bit of fluoroscopy and a little bit of stupidity and a little bit of push. Okay. And you're going to see here as we're pushing and we're looking at retroflex, you can see some Cameron's ulcers there. You can see the whole stomach is now reducing out of the chest. It's no longer volvulized. It's no longer stuck up in the chest. And then you can do anything you want to keep it down there. You can put some of those T anchors in place. You can put 1 or 2 PEG gastrostomy tubes in place to help hold it down. So a very simple solution to a complex problem. All right. I'm going to skip ahead of the rest of them. I'm just going to show you this patient here because we already showed this one earlier. Again, the mesh starts to granulate in. We endoscopically revised her G-tube. We basically did some of those maneuvers. We put some clips around it and made it stop leaking. Okay. I'm going to stop the formal presentation there. I'll stop sharing my screen. And I was asked to specifically talk about the American College of Surgeons courses. And so this is pretty straightforward. The American College of Surgeons, like many surgical societies, every year holds an annual meeting. And at that meeting, they offer a lot of different skills courses. And if you've never seen or looked at the skills courses, you can go online right now and look at the skills courses that they're offering in the fall. I think, Sal, aren't you doing a lab CBDE course? Right, so they're doing a common bile duct exploration course, right? And so every year there is universally some form of a course dedicated to endoscopy, and usually more than one. In past years, along with Dr. Fung as a co-chair, I have done one on managing GI bleeding for the general surgeon, the basics of therapeutic endoscopy. So a lot of the things we just showed you: clip application, injection, balloon dilation, simple therapeutic procedures that you can learn. The courses they offer change from year to year. They do both upper and lower. They do them bariatric related. They do more general. And so you can show up one year and do a course, and come the next year and do another course and pick up additional skill sets as time goes on. For my end, the goal is, if you're not getting the training in your residency and you are not going to, if you're going to do a fellowship, I would absolutely pick a fellowship that has as much advanced endoscopy as possible. And that's true whether you're doing a foregut fellowship, a colorectal fellowship, a surgical oncology fellowship. I mean, I've shown you patients who've got diseases from all of my surgical colleagues. And the reason that I see all those people is that those folks do not have the skill set that I and my partners have to do it. Okay. But I would definitely look for it in fellowship training. But if you're a person who is currently already out in training and you want to learn these skills, this is how you do it. You pick up 1 or 2 new skills every year. You use the scope every time you get a chance. And the more you do, the more you're going to say, oh, I can fix that with a scope. The nice part about being a surgeon is that you always have your surgical skills as a backup. And so if you're trying something endoscopically for the benefit of the patient and you realize that it's not working out for a variety of reasons, you can always fall back on what would be I'm going to say the word textbook, the more textbook, surgical answer, to the question. None of us here talking with you got to where we are now by being intrinsically good at this stuff. It takes time, it takes practice, and it takes repetitions. And so start with small stuff, build up, learn a few new skills every year, and you too can be a good endoscopist. That's all I got.
Awesome. Dr. Paul, I thank you so much. Appreciate that. I think you kind of hit I think one thing specifically you mentioned too is that it's a matter of also just building up your skill set over time. I mean, there's a lot of stuff that I certainly learned in fellowship, that I was able to use that as my foundation and then slowly kind of built upon that over time as well, whether that's even learning at some courses myself or kind of like leaning on other individuals that are doing some new and neat stuff and then just kind of building upon that. And unfortunately, Dr. Juza, I think, is still stuck in the operating room. So if anybody, we still have a little bit of time, but I don't want to belabor it, but I'm gonna share I'll share my screen for another few more minutes here too, and we'll see. Hopefully they'll be able to hop on. But I want to show, I'm gonna show this really quick too, and you guys see that okay? All right. See that all right, guys?
Sal, I don't see a screen at all.
No? Oh, geez. Let's see. Try one more time here. How about if I pull? All right. How about now? Yeah?
Yes.
Good? All right. So same thing as Dr. Paul, I was just kind of talking about. I'm just going to show you a few things here. I'm going to skip around, but I'll give you an example of what we mean by that. I mean, when I was in fellowship, Dr. Paul introduced me to this endoscopic suturing device, which has really kind of become a really big part of my practice. We, in addition to endoscopy, we also do bariatric surgery, and part of that is also building out an endobariatric program, which I'm going to kind of go over here just kind of briefly, but this is just essentially, it's similar concepts, right? We want to take bites of tissue. We want to approximate tissue. And this is really just suturing and operating through the mouth, right? Through an endoscope. And it's, again, really basic concepts. And I generally mean this, where a lot of the stuff that we do is fairly, I don't want to say basic, but very commonplace in terms of what we do in our surgical practice. However, it's a matter of someone showing you how to use the devices, how to learn how to use them, when to use them. But again, this is a device that he introduced to me during my fellowship, and it's obviously made by Apollo, which is now Boston Scientific. But it's a suturing device that you can kind of go in and really place full thickness bites. And in some situation, we use that device called a helix, which is going to allow you to kind of grab and reapproximate tissue as well. And we use this a lot in our bariatric practice. We see a lot of patients who come in who have a history of a bypass, who start to gain weight. And we go in and we actually can revise their anastomosis. And a lot of times, especially when we start to see it about 2 centimeters or more in size, we can take them to the operating room and kind of start to revise their anastomosis. But I kind of want to show you, what we do here is so many different suturing patterns. Most of the time, what I use now is a purse string maneuver to try to get this closed. And what I want to show you this is just how we, how do you put all this together if it will play. Let's go back. All right, there we go. So, the basics, right? First thing is you start especially when basic endoscopy, you're going to start using maybe clips, maybe taking some biopsies. And what that does is really starts to build upon having the ability to maneuver in smaller type places with some precision. So why is that important? Because it builds upon, you kind of continue to build upon your skill set. So as here, what I'm doing is I'm actually cauterize that mucosa of that anastomosis, which is going to help some of this tissue kind of heal together more firmly over time. Obviously, two pieces of mucosa put together, they're not gonna heal, right? So we want to damage that mucosa. And that's where that basic skill set comes in play, because I have the ability to, with a little bit more precision, kind of cauterize the circumference of that anastomosis. And this is a procedure that, we started doing even back when I was a fellow. And I'm going to show you what I mean that in terms of building upon the skill set. So we're using that helix to go in. We kind of grab the tissue, we pull it into the swing arm, we take a bite, and we're going to continue this process over time. And this is going to allow us to basically suture this anastomosis tight. That's a suture cinch that goes in. It goes through the working scope. I'm going to push that cinch in. I'm going to pull up on the suture. It's going to approximate that tissue. And now they have a little bit tighter anastomosis, which is going to probably give them a little bit more restriction. It's going to allow them to take in less calories. They're going to lose some weight over time. Okay. So you're like, okay, that's good. Now remember, this stuff I never really, I did that basic procedure in fellowship, but then over time you start to add on to that. Dark.
You okay, Sal?
I was. There we go. See it okay now? Yeah. So then
Yep.
other things that, go ahead.
I was just saying, yes, we can see it.
All right. So I'm gonna skip over this. Obviously, all right. So how does this come into play? So now, we take that basic skill set that we kind of learned over in our fellowship where we're just doing these stoma anastomoses, but then over time you start to apply it to other situations where now one of the really kind of newer procedures that are really been kind of revolutionized in terms of what we're doing endoluminally is something like an endoscopic sleeves, where we go in and we actually try to mimic a sleeve gastrectomy, where we go in and we put those suture plications and we try to tighten down the lumen or close down the lumen of the stomach without causing an obstruction, but we're essentially just reducing the volume of the stomach. So this is where I'm kind of getting at, where you can take kind of some basic skill sets and really kind of build upon them over time. And then eventually you're going to get to situations where you can really apply it to kind of situations where you're essentially not, you don't see this stuff every day. So I'm going to show you some of the stuff here. Bear with me, it's like freezing. Let's skip to the end here. All right. So in fellowship, we started doing, some stoma revisions endoscopically. We started doing some suturing. And then for the most part, you're like, okay, I'm going to take the skill set. And again, I didn't, ESGs I didn't do in fellowships. But again, we were comfortable with some of the basic skill set. You kind of, if you never did this stuff before, you're going to learn from others who are doing it, talk to them, and then you start to do it in your own practice safely. This is a really nice example here where, we have a, basic skill set, and then you start to apply it to other situations that, you don't commonly see in your practice. Like I never really sutured an acute perforation fellowship, but I did learn endoscopic suturing. We learned these basic techniques. So this was a situation for a patient who came in had a hernia repair. He had a delayed, a little bit leak, probably from a thermal injury. And instead of taking him to the operating room, they had performed an endoscopy. They saw this little defect. And then basically they called me and said, hey, can you come in and try to close this? And, and again, we're in the endo suite when we're doing this. And you can see I'm just basically using the same kind of basic skills that I learned, years ago in fellowship. And again, we were able to kind of close this defect endoscopically. Patient didn't have to go to the operating room, and they did pretty well. So I think for the most part, the message really here is, if you're in fellowship, and you're learning a basic endoscopy, that's great. You have the foundation to build upon. If you are, looking for a fellowship and you're interested in this stuff, by all means, definitely try to seek out a fellowship that's really going to kind of provide to you as much exposure to endoscopy. So as you can see right here, really the future of surgery is probably going to be endoluminal. And it really is, as endoscopy kind of the skill, the tools that we use in endoscope continue to evolve. That's going to be, really helpful in the future. Even as endoluminal robotics are coming down the pipeline, that's also going to be pretty helpful as well. So I just wanted to show just a couple things, really how you kind of start at a basic foundation, and then you start doing stuff where, you go from that elective setting to that acute phase where you're essentially just keeping someone out of the operating room. So it's pretty impressive where that evolution's gone over time. So, well, listen, we can certainly, open this up to the entire panel now. Unfortunately, like I said, Dr. Juza won't be able to come on. The one thing that we wanted to just chat about in regards to what Dr. Juza the message he wanted to deliver was, SAGES is a really great source for all things endoscopy. They have a really nice video library, a repository online. If you are, if you have the ability to log into the SAGES website, and you go down to the SAGES Video Atlas of Endoscopy, there's a couple different sections there that you can log in and watch some of these videos, such as airway, esophagus, stomach, duodenum, small bowel, colon. So obviously feel free to really kind of go on there, look around, and kind of see what you guys want to, kind of the, basics of endoscopy, learning what's normal, what's abnormal. So that's available to you. Over time, hopefully this library is going to continue to grow. Dr. Juza has been instrumental in kind of getting this up and running, and he continues to work on this. And if you ever come across any really interesting videos, let us know. We'll be more than happy to add it to the website. So are there any questions out there from the attendees in particular? Feel free to chime in, send over a chat. We'll be more than happy to kind of answer them.
Hey, Sal, I quickly shared my screen here. I actually had two talks that I found that seemed to be reasonable for tonight, and this one is much older. This is from a lecture that I gave in 2014. So this is a decade-old lecture. And in that decade-old lecture are a number of things that we don't do anymore. There were a number of slides about how to use endoscopy to make sure that your Heller myotomy looks good. Well, we don't do Heller myotomies anymore. This is a slide talking about the future of bariatric surgery. And this proposed bariatric surgical intervention from a decade ago with a theoretical endoscopic suturing device that didn't exist yet is exactly the thing that Dr. Khaitan and Dr. Docimo both spoke about. Okay. And this presentation, this slide deck is fantastic because it's both completely out of date, and also everything that was predicted, like we could think about this or think about that, like they're all things that we actually do right now. And so it's actually kind of fun to go through and see all of these things that we propose doing that we now actually do. So I wanted to share that real quick.
Yeah, I think the one thing about, for all those individuals on the call who has an interest in advanced endoscopy, I can certainly tell you that the field is just evolving at a really a crazy rate. I mean, there's just so many endoscopists out there with really good ideas that are really kind of pushing the envelope in terms of what we can do, especially in the world, like I said, especially in the world of like bariatric endoscopy. I mean, you're talking about people who are doing EMRs with then and then closures of the stomachs to kind of really kind of get the scar in. I mean, crazy stuff, right? But really, again, if you're interested in this field, it's just a really fun and exciting time to be involved in it. As we kind of mentioned earlier, endo robotics as well. That's all coming down the pipeline, and we want the surgeons to really kind of be heading up that field. So, any questions out there for the panelists before we close up shop? All right, so just a couple of closing remarks. Again, I think the message to leave here tonight is, if you don't get advanced endoscopy training in your fellowship, in your residency, there's still some really solid options out there for you. As long as you are interested and proactive, there's definitely the ability to go out there. There's definitely a lot of mentors who are out there who really are more than happy and more than capable to kind of mentoring through the process. If you really want them to, if you really want to continue to learn this stuff as you move along in your career. Most importantly, like I said, just if you're interested in endoscopy, try to get into a fellowship if possible that has really solid endoscopy exposures. If you're in a residency, and you know, and in your surgical residency, and you're not getting a lot of endo, try to find a GI doc. Try to find some surgical endoscopist who you can kind of latch onto and really kind of get some good exposure from them. Okay. And because as long as you get that the basic skill set, you're going to definitely be able to kind of build upon as well. Any closing remarks from Dr. Pauli, Dr. Fung? No? All right, awesome. Well, thanks everyone for your time. If you guys go into the chat, there's going to be a link. It's the post survey link. Please click on that. It's a Survey Monkey link. Try to fill it out, and because obviously we want to continue to do these for you, and we want to be able to provide give you the most value for your time as well. So I just want to kind of say a thank you for everyone who hopped on the call. Thank you to the panelists here for taking the time out of your busy schedules and out of your personal time to kind of hang out with us tonight. And everyone have a nice evening. Thanks again.
Good night.